Okay. So basically today we are going to talk about one scenario, three fractures in upper limb. So basically the scenario is simple: fall on an outstretched hand. This is like a basic scenario. So how are we going to know which fracture will occur when a person falls on an outstretched hand? Basically, when do you fall on an outstretched hand? When you are suddenly pushed by someone, or you trip over something. Okay, so if the age group is that of a child, okay, then in case of this scenario, the fracture would be supracondylar fracture of humerus. And if there's an adult, a young adult, and falls in an outstretched hand, then most likely there will be a fracture of the scaphoid bone, okay, of the hand. This is basically according to the incidence. And if in a scenario you have an old female, then she will have a fracture of her distal radius, and that would be known as Cooley's fracture. Okay. So we are going to discuss it. So discuss it. If a child falls on an outstretched hand, then most likely he is going to suffer from a supracondylar fracture of humerus. So this is a very important fracture, and it can be an essay question. So in children, it is the most common fracture of elbow in children. And the thing about this is that it can be of two types. Okay, extension fracture and flexion fracture. Okay, so this is how we divide it, and mostly they are extension fracture. Now why are we calling these as extension and flexion? Basically, let's say that this was the bone and now it has broken. Now this is based on the position of the distal segment. If the distal segment is coming in a flexed position or in an extended position, that's how we're going to classify it as extended or flexed. Now 97 per like mostly are extension fractures. Now there is another classification which is not the classification is given in Doger, but the name has not been mentioned. Gartland classification. This Gartland classification of supracondylar fracture is like very important. You have to memorize this. There's type 1, type 2, and type 3, and then you treat it accordingly. Okay, so how are you going to divide it? Basically, in type 1, there is no displacement. Okay, the fragments are not displaced with respect to each other. There is no angulation, so not displaced, undisplaced. So how are you going to treat it when there is no displacement? You're just going to treat it conservatively. Apply a cast. Okay, simple. No need to do any sort of reduction or anything. Just fixate it with the cast. Now, in case of type 2, what happens is that there is an angulation which is posterior angulation. Okay, and in type 3 there is also displacement, but there is overlapping of fragments. They get displaced, they get angulated, and then they overlap over each other. Now in type, what is the main difference between type 2 and type 3? In type 2, the periosteum remains intact. Okay, overlapping can occur in both. The periosteum remains intact, so overlapping does not occur grossly because the periosteum is intact, but the posterior periosteum remains intact. But in case of type 3, what happens is that there is complete it is completely opposite of type 1. In type 1 there was no displacement, but in type 3 there is complete displacement. Okay, complete displacement and overlapping. So this is the main classification for these supracondylar fractures of humerus and how we're going to treat it. Now one important viva question related with the supracondylar fractures of humerus, which is the most important clinical point. Okay, why is this so dangerous in children? Because there is an artery which is going to be damaged in case of this fracture, and we are going to have the examiner is going to ask you what is VIC. It is the Workman's ischemic contracture. Okay, so basically what happens in case of Workman ischemic contracture is that there is going to be an ischemia of the muscles because the artery is going to be damaged. I'm just going to discuss it. And there's going to be ischemia of flexor digitorum profundus and flexor pollicis longus. And the problem is that it is permanent. Okay, So if you don't, pay attention to it and just apply the cast and send the child home, it's your fault, because the child's hand would be, unusable for the rest of his life. So it's a flexion contracture, Volkmann ischemic contracture. Okay. So what happens? Basically, the thing is that, all right, so as you can see that this is the brachial artery, which is running just over the, elbow, over the, anterior antecubital fossa, and dividing into the radial artery and the ulnar artery. So over here in the supracondylar region, if there's a fracture, then this brachial artery will be damaged, okay? And also there is, a very high chance of damage to the median nerve also. So basically this is the problem that happens. And now if the artery is damaged, let me show you another picture. Okay, as you can see that this is the artery running, and this is a supracondylar fracture, and this artery is also getting compromised. It's being depressed, it's being entangled, so this can occur. And this is a very nice picture. I hope it's clear. Okay, so you can see that brachial artery is running, and over here this is a fracture. It's, this is type 3 complete displacement. You can see posterior dislocation extension type. And so this artery is definitely going to be compromised and damaged over here. Important thing, to prevent this, and because of this, the loss of this artery, you're going to have ischemia of these two muscles in Volkmann ischemic contracture. So how are you going to, just a second, how are you going to prevent this? What are you going to do? So basically what you're going to do is always do vascular. As we know in basics of ortho, that whenever there's a fracture, you always have to do distal vascular and neurovascular examinations. So you're going to, take the pulse. Try taking the brachial pulse, or try, well, it will be very difficult to take brachial pulse because the area will be tender. So go for the radial pulse, and there is going to be a pulseless hand. Okay. And when there's a pulseless hand, you have to, fix the artery, surgically treat that condition, and, just manage it, because otherwise the child is going to have Volkmann ischemic contracture. So, you have to manage it for the arterial damage that has occurred. Okay, call a vascular surgeon or do whatever. So there can also be nerve injuries that I showed you in the picture, that there can be a damage to the median nerve. So this is it for the first fracture in a child. So how are we going to find out the fracture and come up with an answer based on the age? So if a child falls in an outstretched hand, then it is most likely going to be supracondylar fracture humerus, and a very important thing is Volkmann ischemic contracture, pulseless hand, brachial artery damage, and median nerve damage. So now in an adult, if okay, let's discuss this scenario with respect to an adult. So if an adult comes to you with a fallen outstretched hand, what will he or she present with? Most likely this is scaphoid fracture in an adult. Okay, fall on an outstretched hand in a young adult is a scaphoid fracture. So there will be tenderness of snuff box. Okay, the snuff box will be, this portion will be tender, and the snuff box, let me just show you. So this portion, this triangular region over here, is the anatomical snuff box, and the patient is going to present with history of fallen outstretched hand and tenderness of snuff box. Now the x-ray is going to be normal. What is this? This is a fracture of scaphoid, and it does not show on x-ray. This is very important. Okay, so what do you have to do? You have to always, manage this. Okay, and if the fracture is, let's say, undisplaced, then you're going to go for a conservative, if the fracture is undisplaced, you're going to go for a conservative management. And if the fracture is, unstable or displaced, then you're going to go for internal fixation. So let's say that a patient comes to you and tells you that I fell yesterday on an outstretched hand and I have tenderness in my snuff box and his x-ray is normal. What will you do? You are going to apply a cast. Okay, and what is that cast called? What is that, splint called that you apply to immobilize the thumb? That is known as, it's very important, they ask you this in viva, thumb spica. And for how long does the patient have to wear it? For 6 weeks. And what if you ignore it? Okay, you just don't, x-ray is normal, you just ignore it. What is going to happen? Is going to be a vascular necrosis. Okay, a vascular necrosis will occur, and it will basically this fracture shows up on x-ray late. Okay, so if the x-ray is normal and you ignore it, you don't treat it, then it will worsen. A vascular necrosis will occur, and now you will have to do a bone transplant. And whose fault would it be? Of course your fault, because you should have known that x-ray is normal. This fracture does not show up on x-ray, but now you know. So now things won't be complicated, and you would use a thumb spica and ask the patient to wear it for 6 weeks. Okay, so this is it. And when does it appear on x-rays? It appears after 2 weeks, after 2 weeks, and it is too late until then. Necrosis has occurred. So we have discussed the 2 fractures. Now the third one is for an old woman who falls in an outstretched hand. Basically, this is going to be a Cooley's fracture in the, within the 2.5 centimeter of wrist joint. 2.5 centimeter of wrist joint. The radius basically undergoes a fracture, and it gets displaced. Also, the distal segment gets displaced, and it gets displaced dorsally. Okay, and so there is a dinner fork deformity. I'll just show you. Dinner fork deformity occurs. Now, what is the cast for this? The cast, you should know the names of cast. These are just to memorize. Handshaking cast. Handshaking cast. Why? Because we apply this with the pronation of the forearm and palmar angulation and ulnar deviation. I'll just show it. One more thing that I had to mention was, what are the complications of Cooley's fracture? We know the complication of scaphoid fracture is just one. When you don't treat it, there's going to be necrosis of the bone, and you'll have to do a bone transplant. For Cooley's fracture, there's going to be a median nerve injury, and there's going to be malunion, and there can be rupture or extensor pollicis longus. Okay, how do you treat it? Mostly, basically, you treat it by non-operative methods, but you have to do closed reduction under anesthesia, and you apply a cast. What is the name of the cast? Handshaking cast. This is the treatment. This is it. And operative treatment is rarely needed, if there's excessive displacement, only then. So here is the picture. You can see that the fragment got displaced distally, relatively upwards, and it looks like a dinner fork. And here is the fracture. Now there's another fracture which is known as the Smith fracture, and you can remember it as a reverse Cooley's fracture, which means that you fall on the dorsum of hand, and instead of being displaced dorsally, the segment gets displaced in the volar direction. Then that is known as the Smith's fracture. Okay, so this was it. We have discussed all the 3 fractures which happen when you fall, when someone falls in an outstretched hand based on their ages.